Hello, this is Dr. Jaydeep Choudhury back with another episode of Academics in Nutshell. And today, how to select an antibiotic. So when we select an antibiotic, it's most often empiric. So empiric antibiotic selection should depend on some factors like pathogen, the site, the severity, the comorbidities, and if there is any known drug resistance. As far as possible, we must try to start with a single antibiotic. Now, if there is culture positivity, does it mean infection? Now, sometimes it may be just a contaminant, where the organism is from the skin of the patient or sometimes from the clinician also, or it may be unsterile instruments during collection or incubation. There are some colonizers where the organisms present in the non-sterile part of the body like the urinary catheter or sometimes in the endotracheal tube and others. And ultimately, we have to determine the true infection. If it's bacteremia, we have to determine whether we should treat or if we should not treat. That depends on the identity of the organism. Generally, organisms like E. coli, Klebsiella, streptopyogens, pneumoniae, Pseudomonas and others are true infections. Whereas, if it's enterococci, there is 78% probability. For virulent strepto, it's about 40 to 60. For coagulase negative staph, it's still less unless there is high risk of true infection. And Bacillus group, Corynebacterium and few others are rarely true infections. So when we decide on a definitive therapy, first we have to confirm the microbiological diagnosis, ideally usually based on culture with antibiotic sensitivity. So first we suspect, then we send for culture, then we start antibiotic empirically, and when we get the sensitivity report, we, if required, we may step down to a narrower spectrum of antibiotic depending on the sensitivity. Rarely we need to combine two or more antibiotics. The justifications are if there is a serious bacterial infection like in hospitalized patient, if there are mixed infection like road traffic accidents and others, to delay the development of resistance, the commonest example being tuberculosis, HIV and falciparum malaria, and when the true synergy is required like in the bacterial endocarditis. Sometimes we need to change the antibiotics. One is escalation, where we have to go for a higher antibiotic based on culture. It may be either substitution or addition of an antibiotic, or de-escalation, which is a method of narrowing the empiric therapy. There are definitely some benefits of de-escalation. It decreases the antibiotic related adverse effect, it's cost saving, and the MDR organism in the hospital environment are also reduced. And it has been found that de-escalation outcomes are non-inferior than continuing the previous therapy. Another important aspect is sequential parenteral oral. Some antibiotics like ciprofloxacin, linezolid, metronidazole, co-amoxiclav, where we have the oral counterpart as the IV or IM counterparts are available. But sometimes we need to switch. Like if we are giving ampicillin, we need to switch to amoxicillin for oral. If it is ceftriaxone, then we need to go on cefodoxime or cefixime depending on the site of the infection, for vancomycin, linezolid, and so on. So selection of antibiotic is very important for proper management. Thank you. See you again.